Hi guys, welcome back to the Gate Guys podcast. Sean Allen here. A little bit of housekeeping here. First of all, sponsor the show today, NewBalanceChicago.com. Multiple stores in the Chicagoland area. New Balance is one of the few companies out there that offers various widths in shoes. There are companies out there now that offer a wider toe box like Ultras and Topo. And some other companies are actually starting to widen the toe box in some of their shoes like Brooks. But New Balance is one of the few that, if not the only maybe, that actually offers variable toe box widths for your foot type. With many shoes out there, from very low drop to significant drop to trail shoes, everyday shoes, stability shoes. They've got it all. So go out and check NewBalanceChicago.com, multiple stores in the Chicagoland area, and maybe if you mention the Gate Guys, they might still give a discount. We're not sure about that, so don't hold us to that. But if you're a New Balance fan, head over to one of their stores in the Chicagoland area. You can probably still get some stuff online through those stores. And if you haven't been to one of their stores, go check them out. They really are doing a fine job. So NewBalanceChicago.com. And one more thing before we head on to the podcast. I recently listened to one of Sam Harris's podcasts, the Waking Up podcast, and he had brought together or forward to some enlightening information as to why, perhaps for those of you who are not social media savvy, why you're not seeing some of our information. And I kind of parsed some of that into something that might help you guys. But we're still putting stuff out, maybe a little bit less. We're about to dry run something on April 28th that could be a program for you guys, and we're looking forward to that. But in the meantime, we're still putting stuff out. So if you're not seeing it, it's because you're probably following more and more people, and it's altering your feeds on your social media. So this is something I pre-recorded a while back. Maybe this will help explain some things before we head into the podcast. For example, Twitter. If you're following more than 100 people, the tweets are getting pushed down to the bottom, and you're probably not even seeing what we're doing. And on Facebook, if you're following, anywhere of, 50, 100 different people or different sites, unless you've favorited them, and you can do that on Facebook, you can kind of prioritize tweets or Facebook feeds that you want to see. It's even arguable by some sources that still stuff is getting filtered, and and we've experienced this personally too, and I'm sure you probably have too, wondering why haven't I seen anything from so-and-so or from this site or what have you. It's just because of the volume of the information, and there's obviously some filtering that's going on for logical reasons, because it's just no way to consume all this content, nor is there any way that Facebook could or any of these social media pages for that matter could curate all that content towards you. You'd be overwhelmed, and then you'd probably never see anything. So the solution to this is either an email newsletter, which, God, who wants to get those anymore? Although it's arguable, maybe we should, because then you guys could always see the new content. But, it's a few keystrokes or a few finger pokes away from typing in thegateguys.com or just going over to our Facebook page directly or to our Twitter page or any of our other social media sites. So we encourage you that if you're really serious about following our stuff, just once a week, make sure you check in if you haven't heard from us, because in all likelihood, your social media feeds have filtered things down into things that you may follow a little bit more frequently. And so just know that our stuff is out there, and that this is probably just going to become a bigger problem over time. There are people, for example, Sam Harris rings a bell, and there's a couple other people. Names aren't important, but what they're doing is they're actually paying each one of their posts. They're sponsoring their posts, and so they're actually paying every time they put out something like a podcast or whatever, so that they know that it's hitting the feed of the people who have liked them or followed them. So that's all great and fine and dandy, and we do not have that kind of cash flow. So we've got a couple things here. I'm going to put them into the show notes. They're neuroscience. Ivo and I kind of alluded to them in this podcast. Basically, neuroscience pieces were related to new technology. There's one here. Stanford develops a computer that literally plugs into people's brains. That one's from entrepreneur.com. It's in the show notes, as always. This is a very interesting one because it's taking some of the things we have talked about previously regarding the singularity and moving people into an adoption of technology into our human biology. This one was interesting because they have this 100 sensor electrode that they literally, you see in the video, screwing this plug, this port, this probe into the top of this lady's skull, and allowing her. She's a quadriplegic or paraplegic. I'm not sure which. I got to go back and look at the video, but it's on the Entrepreneur article, and she looks like there may be some degree of locked in. I'm not sure if she can talk as well, locked in syndrome, but basically, once again, we are finding ways to use technology to link into the brain in terms of the neurons directly to create from a thought to a computer interface interaction. And so that article really was nice, but it spurred the next one from Elon Musk saying that humans must become cyborgs to stay relevant. This one was in The Guardian. We'll put this one in the notes as well. And, this is really on that basis of neuroprosthetics, allowing us to, as Elon Musk likes to say, communicate complex ideas through. He's got this new thing called the neural Neural lace. It's an injectable mesh-like lace that fits on your brain to give it a digital computing capability. He's working on that right now. It's not reality yet, but I'm pretty sure that it will be. And so, once again, this kind of comes down to receptors. We've got smell and sight and touch. We've got all these different types of receptors, and they plug into our brain. And I guess some of the premise behind my thought on throwing this into this podcast was that if we had receptors that could detect Wi-Fi or Bluetooth or radiation or infrared or, subsonic sound like dogs or what have you. If we had the receptors, the brain would be able to take that information and utilize it, but we don't have the receptors. And we are quickly seeing that through some of these cyborgish, if you will, means that have come along with prosthetics and neural prosthetics, where they're actually taking a prosthetic hand or something like that, and they're interweaving it into the nervous system. You're providing a artificial receptor that the body once didn't have, and the brain is learning how to reinterpret that through the help of technology in terms of computers and software. So, in his article, Elon Musk suggests that we're going to have to basically, if we want to keep adding value to the economy, we're going to have to augment our abilities through a merger of our biological intelligence with this machine or computer intelligence. And failure to do this may kind of put us a step back in terms of the progressions that others are going to be going through if they adopt that. And so, the thought being that if we can interface and create these types of scenarios where we could implant an ability to, have, this amazing smell like dogs, or detect Wi-Fi or radiation or what have you. And I saw something recently that said we are only able to detect 1/100th or 1/10,000th of the light spectrum that's out there. All we do is we see the colors of the rainbow, but there is just so much more there. So if we had an ability to create a receptor that could detect these types of things through the advent of adding technology and artificial intelligence or machine intelligence into our system, the brain would be able to then take whatever that information is and actually detect it and interpolate it and integrate it. So he's suggesting that if we really want to go to the next level and compete with what's coming down the line here in terms of technology taking over and artificial intelligence taking over, we're going to have to basically learn to merge our biology with this technology. So, interesting article, some interesting thoughts. Sorry for the rambling there, but I think it's important because this is where things are going. Ivo and I have alluded to this many a time, and it looks like it's just accelerating here. So, this is going to come into human movement and gait and repairs of injuries, and things are really going to be moving quickly here in the next decade, if not sooner. So we want to keep you guys on the the cutting edge of what's going on there. So enough rambling. We're going to head off into the pod here. Thanks for being here with us, guys. We'll see you on the other side. We're back for another podcast here. Dr. Ivo, how are things out there in Colorado?
Things are sunny. We are losing our snow rapidly, but spring break is here, and we've got lots and lots of folks here on the slopes, and lots of broken people in my office. So
nice, I guess. Not for your patients, but just for the listeners. We are on March the 3rd here, 2017, and we're a couple weeks back from launching. We're going to be launching one here momentarily. You guys will already have gotten that by the time you hear that, but we're trying to keep 2 or 3 in the hopper here. So by the time you get this, it'll probably be the end of March. So just so you know. Anything cool in the clinic before we go on to neuroscience stuff here? Anything that piqued your interest?
There is always cool stuff in the clinic. I had an interesting plantar fasciitis case come in earlier in the week, and the interesting thing is a lot of people, and I think you'd agree, that have plantar fasciitis usually have a loss of either hip extension or ankle rocker. And this particular gal had none. She was Gumby girl. She basically just had very little incompetency of the musculature of her feet, and is doing very well. It was only a couple treatments, but she's doing great already. So just because it looks like plantar fasciitis and smells like plantar fasciitis, and it doesn't always mean it's going to have the same cause.
Well, that's interesting, and that kind of goes into one of the things we've got on the itinerary. So since we're there, let's just stay on this thread of thought here that, a lot of the times, and here's how I approach things, and I hope other people do, but I'm always welcome and open to learning from others, but you have to have a competent foot. The foot has to be stable enough in order to get the appropriate amount of ankle dorsiflexion, that sagittal hinging motion, to occur at the ankle joint. So you need a stable foot, competent foot, in order to expect to even get close to normal ankle range of motion. Then above that joint, you need to have another stable joint, the knee, for the loading response. If you load the knee and it's not stable, you're going to get some valgus loading, some sudden hyperextension or hyperflexion type movements that are all of a sudden during the loading response. And then above that, you want a mobile hip again. So it's no coincidence. And then above that, again, they shift again. This is stuff that you and I have kind of talked about in a million different ways over 5-6 years of podcasting. We've never maybe said it that way, although I've been trying to say it a little bit more cleanly to folks in the blog over the last week or two in my blog posts, that if you've got someone who steps down and they've got a hyper-immobile foot that's just collapsing, like the case you just talked about, you can't expect to have normal ankle rocker. A lot of the thoughts are that you're going to have excessive ankle range of motion because you've got this sloppy foot underneath it. But the truth of the matter is you don't need a whole lot of ankle rocker if you have a lot of foot pronation, because you're going to be moving sagittally forward through the collapsing arch. When the arch collapses and the talus plantar flexes and adducts and medially rotates, i.e. pronation, and I know you like to use some other references, and it's all good, it's all right. But when that talus is moving in that direction, that basically, those motions carry the talus, or the tibia, forward, because it's sitting on top of it, and it carries it forward through that sagittal motion. So the sagittal motion really is an ankle rocker. It's actually foot pronation and internal rotation that's carrying that client forward. So we've always said, geez, we should just have a practice built off of ankle dorsiflexion or ankle rocker and hip extension. Well, that's because those are the two mobile joints that you'd like to have between the two stable interfaces at the knee and at the foot. And so, you have these alternating, kind of goes off of, in some respects, the Yanda's, Vladimir Yanda's layered syndromes, if you will, which is a play off of the upper and lower cross syndromes intermerging. It's more complicated than that. Those were fairly remedial principles to help people understand the higher levels of complexity between hypertonus and hypotonus in the body. But it brought to my mind that ankle rocker case that I put up recently on that guy that had the trampoline injury. Do you remember that one?
I do.
Yeah, the guy was he dislocated the talus, and he was put into a rocker boot for 7 weeks to try and stabilize the thing. And so not only did we take away foot mobility and ankle mobility, we took out both of those. So the next joint up is the knee joint. Well, he's trying to move across this brick on the bottom of his limb. So the next place that you're going to try to impart motion is in the knee. Well, if you've ever been in a rocker boot, you can't really move the knee into much flexion. But during the early loading response, because of the way the cam rocker boot is set up, you can easily go into knee hyperextension. And so he's finding mobility in a retrograde knee motion because of the loss of mobility down below. So, these principles just keep coming up over and over and over again. And so obviously, you could take your case and you could either teach them some foot stuff or put them into an orthotic to help them control that to get some of the problem down, or you could do a combination of both, right?
Yeah, we just do below knee amputations usually on these cases, so
it's a lot less hassle.
It's faster.
Right? It's less thinking.
Yeah. No, I mean, we obviously do a ton of exercise. We use acupuncture / needling as a adjunct, to all the stuff we do. We'll use orthotics, but with this particular gal, I always like to try, let's see if we can do it without first. And I know you like that, thought too, although there's some people that come in and it's just, they definitely need that. But the point is, here's a lady in her late 40s, early 50s that really doesn't need something else to stick in her shoe at this point. She just needs a more competent foot. And she's super motivated because she's been dealing with this for over a year. And when people are at the end of the rope, they'll pretty much do whatever you ask them to do, especially if it's working. So we're hoping for excellent results and for her to continue to do what she needs to do. And, along the way, you educate them about footwear and, regular exercise and all of the other things that need to come into play as well. So,
yeah, I mean, there are the cases where the people just I need to be out of pain here. I have no problem doing the work. But how long is this going to take? Oh, it's going to take that long? I'm still going to be in pain? I mean, if you can't deliver at least someone with some, reasonable expectation, they're going to go somewhere else and get that orthotic. So sometimes you need that orthotic just to say, look, this is temporary. Let's get you out of pain, but this is no, replacement for improving the actual function of that foot. And recently on the social media page, mostly on Facebook, where people tend to chime in, and some people were saying, well, what's the fix? And people always want that from us, don't they?
They
always
bullet.
Want that. What's the magic recipe? Tell us how your mom's brownies are made. And we always refrain from doing that, because if we did that, we would be no better than a lot of the people on YouTube who are showing the golden exercise of the day to increase internal hip rotation or whatever. And rarely do they ever throw out the caveat that, hey, man, this is a big process and this is only one little piece. And I understand that they're trying to throw out a little piece, but those people are really no better in that they're just throwing out here do this, but forget about all the other components of it. So they're not giving you the recipe either. So that's why we don't do it, because there's just so many issues. And if you guys want to know the issues, come over to our online ce.com or chirocredit.com lectures every month, and take some 30 odd courses or whatever, and try to get up to speed on foot types and torsional types and shoe anatomy and orthotic therapies and corrective homework and as the list goes on. This is for the listeners. I mean, this is a complex thing, and so sorry, we can't give you the recipe. It's because there is no single one recipe. Sometimes, as I like to say, the frosting does have to go in the bowl first when you're making those cupcakes. There are those people that need a really bizarro recipe for it to work for them because they've got bizarro body parts and bizarro motor skills and aberrant sensory, whatever. So that being said.
With that being said, and that's an excellent segue to some of the Achilles tendinopathy stuff that we've got on the docket for today. And one of them that I think is applicable to this case and your case as well is the Wiesenbeek study talking about Achilles tendon blood flow.
Mm-hmm.
And this was out of Medicine, the Scandinavian Journal of Medicine and Science and Sports. But to kind of distill it down, they looked at runners, 35 plus or minus 10 years. They looked at 25 of them. So, a cohort of a reasonable age difference, but not necessarily huge. And what they did is they looked at blood flow, and they looked at calcaneal inversion at, they called it touchdown, but at initial contact, and then eversion at mid-stance. And the bottom line, what they said is that the more calcaneal, well, first of all, the more inversion there is, a lot of times, the more eversion there will be. Now, not always, if you have a rigid rear foot varus or something like that. Yeah.
And think, and for you listeners, just think, if these are terms that you're still kind of, if this is a little French for you, think more inversion as more supination. It's not exactly the case, but it's a component of it. And think more eversion as more pronation, just in case you're wondering which way the calcaneus is going. So
so medially, laterally. But anyway, what they found is that folks that had more eversion had less blood flow in the Achilles tendon. And they go on to, surmise in the study, or suggest, as they put it, individuals with increased inversion at touchdown and increased eversion at midstance during shod running, all these folks were in shoes, antipronation measures could be useful in preventing and managing Achilles tendinopathy, because tendinopathies, one of the things besides overuse can be ischemia that can cause that. So no rocket science here as far as things are going. If you think about if you take a muscle and you put it through a range of motion and you put it in a lengthened sort of position, and then you go to lengthen it a little bit more and load it, of course you're going to shut down some of the blood flow, just strictly from the mechanics and physics of what's going on, not even to get into the afferentation that's occurring because of the increased joint movement, which is going to cause localized vasoactive changes. They're going to occur at that. So it was interesting. And when you look at folks like that have that sloppy foot, for lack of a better word, you need to start thinking about looking for trophic changes around the ankle joint. What's the skin like? Is it significantly different? Is it calloused? Is it not calloused? Is it dry? Is it wet? What does the skin look like, color-wise in the area? Are there little things which are growing on the bones, exostoses and things like that may or may not be occurring? What does it feel like? What is its shape compared to the opposite side? And all these things are going to give you clues. And then, look at their footwear, look at the back, look at the heel box. Do they have rubbing on one side or the other with some of the material missing? So it's just all part of the puzzle. And I don't know exactly where you were going for having this in the IT for today, but when I read this, I immediately thought of that lady that I saw and, your case that you had up earlier this week, because we classically think of, that kind of stuff. It's like, they don't have ankle rocker, they don't have hip extension, and that's the go-to. And in a lot of cases, that is the case, but in a number of cases, it's not the case. And now that people out there are getting more educated and sharper on things, they're starting to see, and they're looking further, because it's like, you got this, do this. And I think you put a paper in there later talking about gluteus maximus, I believe, but it could be medius exercises along with abductor hallucis exercises, and those, one affecting the other. And, you can cookbook some of this, but it's also going to cookbook your results, which means that, okay, so the average person gets 70% of people better. You're going to get 80% of people better, 85%, but you still have that other 15% of recalcitrant cases that, you haven't really it hasn't gotten better because you either haven't gotten to the cause or their anatomy is limited in such a way that you can't get to the cause,
Mm-hmm. I mean, you have to be careful. If you're just looking to reduce the symptoms, you're probably not, there's a great chance that you're not fixing the problem. I always say, look, I can put a stone in your shoe and make you bear weight differently through your shoe. And if that gets rid of your pain, that doesn't mean putting a rock in your shoe is the right answer. And, you can approach an orthotic the same way. Just because it makes you feel better doesn't mean we've addressed any of the underlying pathology that's caused your problem. But you feel better, so you think that's the solution, and it's not the solution. The load's still coming through there. The knee above that foot is still saying, hey, look, I see what you did down there. I'm not an idiot. I see what you did. What about all that weakness that's still sitting there? We're just promoting more weakness down there, guys. I still got to take the load up here. And, the hip is looking down at the knee going, yeah, and if you can't take it, I got to take it. And so the system just goes through all these adaptive changes. So it's one of my beefs with orthotics when they're not used as a therapeutic tool. They're just used as here, put this in the shoe in your foot for the rest of your life. You may have to come back every 2 years and increase the prescription on it. But and it's why, if you've really been in orthotic therapy, there's a lot of tweaking that's usually necessary if you don't get it just right. The patient's like, it's a little high on this side and it's a little lower on this side. And can you grind it down here a little bit more? And it turns into, and I know you've had those cases too. It's just like, oh my God, this patient is like princess in the pea foot is what I call it. But, you just can't take your clients and say, you need more hip extension and more ankle dorsiflexion when you've got a sloppy foot below it. Because a lot of that stuff that you're trying to put into the patient isn't actually going where you think it's going. That foot is just getting prostituted even further. So why did I put it in there? I just, it just felt like a kind of hip Achilles tendon, foot pronation kind of day when I put together the itinerary this time. And, there was another article here, since we're just flowing with things, the Achilles tendinopathy article that they looked at insertional Achilles tendinopathy, and they basically looked at range of motion and isometric plantar flexor strength, meaning the isometric strength of the gastroc soleus posterior mechanism. And during the stair ascent testing, when they're going upstairs, the tendinopathy group used greater end range dorsiflexion, meaning they went further into dorsiflexion than the control group. They used less plantar flexion than the control group, and lower peak ankle plantar flexor power than the control group. So all those things tend to tell me, well, they're using more range without protection on the dorsiflexion, and they're not able to get what I call top end calf strength in order to get the appropriate amount of ankle plantar flexion and heel inversion, amongst other things, during pushing off. And so all those things mean too much Achilles load, too much inappropriate Achilles load, too much too soon, too fast, too often, too. So did you take anything else from that article?
The article originally, it talked about that. And what first thing I thought about is, well, why? Why are they using greater end grain dorsiflexion? Is it a proprioceptive thing? And less plantar flexion makes sense because you're going to get arthrogenic inhibition, with mechanical issues that are going to occur about the ankle, and less plantar flexor power because you're going to put more tension into the tendon. One of the things, and we should just let our readers know that they're looking at, and this is common, we do this all the time, like the article talks about one thing, but we'll pull something out totally different to talk about that they're not even talking about. These people were looking at insertional Achilles tendinopathy and ankle biomechanics, and what they were doing is comparing people, like, in other words, do people that have Achilles tendinopathy on the table, do they have a decreased ankle dorsiflexion range of motion? And that's what they were looking at here. And they found that there's really no differences. And we've been saying that for years. It's like, well, you can look at it on the table, and that's going to give you some info, but you need to get them up, and you need to get them moving, and you need to see, well, what happens when we put gravity in the situation? And now what happens when we, superimpose the nervous system on top of that, and what's going on? So the main thing I was thinking of is like, well, why are they using that greater end range dorsiflexion? And your reasoning that, they're just in unprotected territory really makes a lot of sense. I hadn't really thought about that. We would need to look at 1A afferent activity in tendons, and is that changed, or how is that altered electrophysiologically when we have pathology of that tendon? In other words, tendonitis, tendinosis, that sort of thing. Does that affect the reflex? The 1A afferents are the afferent, the sensory fibers that come from that tendon that are going to feed back to, well, ultimately the cortex, but largely it's a segmental reflex in the cord, and then feed back out to help adjust one alpha motor neuronal activity, in other words, extrinsic muscles, as well as the small muscle spindle activity, and that, of course, is going to be modulated by, cortical information as well. So, anyway, that was, I guess, what I took out of it. So,
well, and you always have to wonder. I mean, when I read these articles, I wonder, gosh, do they know? I mean, not that I know everything. I certainly don't. But do they know that increased dorsiflexion might not actually be from the ankle mortise? It might be from too much subtalar pronation because the foot intrinsics are weak and the actual heel is dropping because the arch dropped. Because that could actually play into this a little bit too. But, I know that's not the parameter they're measuring. But, it just tells you, I guess what I'm saying is that these articles are so specific sometimes that you almost have to do what you and I are doing, is just, okay, here's what they said. Now let's just kind of digest this, and how's this play out into what we know? Because a lot of the times people come back at us and go, that's not what the article showed, and the p-value was less than this, and the sample size was too small. I care about that stuff, but I don't care about that stuff. I care about the finding and then putting it into our formula and into my understanding. And into the process. I mentioned in another post this week, after hearing Neil deGrasse Tyson's recent podcast on Joe Rogan's podcast, he went into something and I had to stop it. I wrote it down. He laid out this continuum towards insight and wisdom, and he said that things move from facts to knowledge, and that's about as far as a lot of these studies go. But then you have to take it into experiential use, which turns it into wisdom, and then after you've done it long enough and you've seen every single corner of that son of a gun, then you can go into insight and go, wow, well, it's not always that case. And so he moves from fact to knowledge to wisdom to insight, and I like that. And it's kind of why we don't, to go back to what we talked about at the beginning, why we don't give out this recipe of homework, because a lot of the folks who are asking these questions, no offense, because I'm as dumb as a rock on some subjects too. They don't have the wisdom or insight, and so all they're looking for is the facts and the knowledge to implement a recipe, when there's just so much more involved. So, so we try not to cherry pick these articles. We try and pick an article that says something and then talk about it. And that's for those of those folks out there that like to text us and remind us that this is a crappy study. A lot of times we know it is, but in everything bad, there's probably something useful if you're actually sitting back far enough and looking at it. And that's the way I like to pick these things up a lot of the times. I really don't care about what journal it came from. A lot of the times, if there's a message in there that has something of value that triggers some insight. So,
yeah, the other thing just about the study, too, that we should just mention here is the study's all done on individuals that were 50 years old and older. So are we, is this germane to this population only, or are we, can we extrapolate to the general population? So, just think about that stuff. You always want to look at, how many cohorts, did they mix them male and female? Are they athletes? Are they non-athletes? Are they experienced, non-experienced? What parameters are they using to measure? And you're talking about, we could say, oh, well, they're measuring ankle dorsiflexion. Well, they could be measuring, tarsal metatarsal motion, intertarsal motion, or ankle dorsiflexion, or all three. And that's going to change whether the great toe is extended or flexed when they're doing the actual test, because of the tension on the plantar fascia and the posterior compartment, yada, yada, yada. So, you really need to distill down a lot of times, well, what are they saying? And what we're talking about is, stuff that really was related but not necessarily related, to the study.
And that age thing you talked about is absolutely critical too. And that's one thing I always look at when I look at these studies, because if it takes a bunch of teenagers, I mean, let's face it, guys, their system hasn't gone through as many cyclical loads. So you can push really crappy biomechanics through a lot of these younger people, and their system has a certain amount of resiliency. I mean, don't tell me that someone who's got a really flat foot, who's 15, doesn't have more resilience in the posterior tibial tendon than someone who's 60 with the same foot type. I mean, there's a number of aberrant loads that have gone through that tibial posterior tib tendon that's completely different than that 15-year-old. I mean, that thing has gone through insufficiency over and over again through stretch cycles so many times. So when you look at the study, you got to also look at those issues. I mean, there's just more resiliency in a younger system. They're going to go through far more number of cycles of deformation before they start expressing pathology. So keep that in mind too.
Everything with a grain of salt. So while we're on the roll here, let's roll on to British Journal of Sports Medicine talking about eccentric training in patients with chronic Achilles tendinosis. And there's something real specific I wanted to talk to you here. But anyway, what they're doing is eccentric training on these folks, and they found that it helped to normalize tendon structure and decrease thickness at follow-up. So it's that whole tension versus compression that we've talked about, in other podcasts and stuff, and this one, for a chronic Achilles tendinosis. What my question to you is, and has nothing to do with this study, is do you use eccentric training with your folks for foot exercises and people with foot incompetency and plantar fasciitis?
I do. I use a lot of isometrics too, but I mean, you folks have, if you've been with us long enough, some of my minor technical beefs with the Yonda short foot exercise. I mean, it's just I like to try and have people go through exercises that are actually more functional in terms of how the gait cycle is utilized. It's not that it doesn't have some value, but I do think that it might be time to modify that a little bit. And I've written an article about it somewhere on the blog. I think we'll try and put in the show notes. If not, you can just type in short foot on the search box on our blog. But for me, it's all about loading. And a lot of these people that come in, if they've got, whatever it's a plantar fasciitis or an Achilles tendonitis, I try to get them into a normalized biomechanical position, and then I start adding some loads. A lot of the times when we know a lot of these tendonitis, tendinoses, and tendinopathies, etc., they don't like that concentric compressive type loading. So I tend to do more static loads and eccentric loads, at least first up front. But, I need to get them into a loading response that they can tolerate, and then we just keep repeating that loading response, sometimes going quite heavy to try and get some changes into the system where they can make an adaptive load response that's better than what they came in with. Because if you do give them that, they're more likely to actually be able to control some of the deforming forces that cause this. So in answer to your question, yes, I do use these types of things. A lot of the ones, that one that you showed me, the lumbrical loading with coming up onto the ball of your foot, pressing the toes flat, slowly coming into heel drop, to try and get some type of lumbrical response is something that I use all the time. So I'm not sure if I answered your question.
You kind of did. But I guess what I'm getting at is, what are some of the other methods you use to eccentrically load the foot? So, we know calf raises. Yes, that's been beaten to death in the literature. We've got the lumbrical exercise we've talked about before. But, other than using a TheraBand, because I'm a big extensor guy, as everybody who has been listening to this for any length of time knows, I'm all about driving extensors, not flexors, especially in the feet. And it's all about dorsiflexion. It's all about the long extensor tendons, the short flexors, but the long extensors. But how else besides that, and I guess I'm looking for more creative ways to eccentrically load that stuff. So besides, like I said, and the thing I don't like about TheraBand is it's a progressive load. In other words, it becomes more as you approach full extension, of that tendon. In other words, it's not isotonic throughout the entire range. It's a variable resistance isotonic in that the resistance becomes greater because the tension in the TheraBand becomes greater.
Mm-hmm.
Yeah. So I'm wondering, what other sorts of things, do you do?
Well, and that's a good point, because a lot of people just use the elastic band, TheraBand type mechanisms, and I try to stay away from that when it comes to Achilles type things and plantar fascial, only because I want that constant load response, because remember, these tissues are really, they're not really resilient and tolerable to all these variable loads. So I try to keep the load as static as I can. I mean, for example, you got to remember, the gastroc crosses the knee, the soleus doesn't. And so the mechanism is going to be different to load one over the other. So, I mean, just think about having someone come up onto the balls of their feet. Now, remember, you can come over the outside of your foot in a more like a varus type loading response, or you can come over your big toe and get into those peronei and drive that medial ray, big toe type loading response. And you have to look at both of those too in heel rises or calf work, because you've got a medial and a lateral gastroc and soleus, so you need to be able to variably load those. And quite frequently, a lot of these people have these type of Achilles problems, if you will, since we're talking about that, because the bundles aren't loaded appropriately. You get someone who's walking on the outside of their foot, they're going to have tons of medial gastroc soleus strength, but they're going to have a lot of stretch load in that lateral compartment, gastroc soleus type thing. So you need to understand that comes down and plays into this kind of a twisting aberrant loading through that Achilles attachment, which can be some of that vascular stuff that we talked about. You're distending the vessels on one side, which can shut them down, but you're compressing the ones on the other, which can shut it down. So for various reasons. One patient asked me, well, how's that happen? And I always said, well, here, I grab a TheraBand, and I said, look at the end of one of the tubing bands. And I said, look down the hole of that. You can see that it's a patent lumen down the center of that tube. And so I pull on it, and they go, oh, it gets smaller in the middle. Yeah, it's, you're stenosing that vasculature. So during a loading response, you got to think that these types of things are happening to the vasculature, to these tendons, and in the muscle itself too. Excuse me. So keep in mind that because of those types of things, my heel raising in my clients might focus more on getting over the lateral foot or more over the medial foot, depending on what I find in their homework. I may have them do more calf raises with the knee bent than with the knee straight, depending on if I'm trying to get more gastroc or more soleus. Now you can combine it. You can get bent knee over the big toe to get more lateral compartment soleus and peronei, whereas lateral bent, or anyways, you got the idea. You got all these different variables, which is why, again, we don't give the remedies of homework and exercise, because they're just in this explanation right here, there's at least 4 variables right there on how to get into the posterior compartment differently, depending on how the foot is loaded and what position the knee is in terms of flexion or extension. So I like to do body weight type stuff that way, but sometimes I'll just have them do, if it's a lot more bent knee work that I need to do, because I'm trying to get more of the deep lower posterior mechanism, I'll just have them put maybe a 20 or 30 or 40 pound kettlebell on that knee and have them work on the mechanics of, whatever I'm trying to do, lateral foot, medial foot, and try to get them into a loading response. So I hope that gives you some kind of an idea what I do with some of my stuff. Mm-hmm. I'll even have people do some of their bridge work. If I'm having them do some hip work, I'll have them go onto the balls of their feet. So they're laying on their back, they're into a bridge, raise up onto the ball of your foot, and learn how to sustain loading in plantar flexion while you're doing some hip extension work. Oh, wait a minute, that's kind of contrary to the ankle dorsiflexion hip extension. Well, it is until you get into terminal stance, and now you're into both of those responses. So I try to play around with these things a lot that way. A lot of the times when you play around enough, the patient will start to go, oh, they're in a bridge, they're on the ball of their foot. Man, that I can tell that calf is weak on that side. I can't keep that heel as high. Oh, I can't feel my glute as much on that side. And they start going, oh, I kind of get how this all comes together.
So at what point do you decide to just stick a rock in their shoe?
Usually it's at 7 o'clock at night on a Thursday after a hard week, and I don't want to think anymore. And I'm just like, you know what, Mrs. Jones, I got nothing left. Here's a stone. Pay for it at the front desk.
There you go. There you go.
Of course, in jest, but yeah. It's one of those things, and you and I've said it before, the more you know, the more things you got to consider, and the higher the variables. But if you don't know a lot of this stuff, you know, an off-the-shelf orthotic is looking pretty simple. It's a lot less brain power, and if the patient feels better, all of a sudden you look like a genius, but you really don't know what you don't know, which goes back to that other Neil deGrasse Tyson quote. Since I'm in a love affair with him right now, that, you know, knowing enough that you think you're right, but not enough to know that you're not right at all. Something like that. I'm sure I bastardized this, but you got an idea what I'm talking about. So,
well, since we're there already. You put another study in there that was an awesome study. I hadn't read this, and which is surprising since it was from March of last year. But it was talking about glute max and abductor hallucis strengthening exercises and its effect on navicular drop and lower extremity activity. And this is out of Journal of Physical Therapy Science. But anyway, what a great study that was, you know. Basically,
go for it, because I know the abductor hallucis is one of your favorites.
Well, it's just, you know, what they did is they gave people, you know, exercises to do that combined both Gmax as well as abductor hallucis. And the abductor hallucis exercise was basically the toe spreading exercise. So if you go on to YouTube or our blog and you type in the lift, spread, reach exercise, that's what they're talking about here. It's for the long extensors of the toes as well as the dorsal interossei musculature. Anyway, they found that people that did both sets of exercises had less navicular drop, less midfoot pronation, than people that only did one or the other. And the group that they did was basically, they split them into the combined group as well as just toe spreading exercises, which is the lift, spread, reach exercise. So it was really interesting that they came up with that, which just goes to show you that the glute is so important in the gait cycle, and that's why we give, you know, folks all this stuff. And the immediate thing that came to me when I was looking at it as well, of course, the more muscle groups, you know, is going to cause more temporal and spatial summation. So we're going to get a better result. We're putting more stuff into the motor neuronal pool, you know. When you do that, generally either the system, you know, shorts or it works better as far as that goes. But it was neat. Not so much that the exercises were anything earth-shaking, although it does give the lift, spread, reach exercise a lot of credence here, but just that you need to consider those things. And gosh, I mean, how long have we been talking about that, you know? And you got to think about, you know, your G-max, you got your three divisions, your iliac, your sacral, as well as your coccygeal division. And the iliac and sacral divisions are largely, extensors and external rotators. So, you know, did exercising this create increased passive tone in that musculature in that externally rotated lower leg and cause less navicular drop? Mm-hmm. You know, is that part of it? Was it, you know, because obviously when they did just the lift, spread, reach exercise, which works the abductors, that's not going to affect it as much. But if you think about that with the lift, spread, reach exercise, what are you doing? You're firing the long extensors, okay? So do the long extensors do much to hold the arch up? Well, a little bit, but it's more the tibialis anterior. 2, it works the dorsal interossei musculature, okay, which is good, but the dorsal interossei are pretty much limited to abduction of the toes. And number 3, the lift, spread, reach exercise is going to work, in addition to the abductor digiti minimi, the abductor hallucis. Well, if we remember about the abductor hallucis, on most people it's not an abductor, it's a flexor of the toe, particularly if there's any degree of pronation that's occurring, because it inserts underneath the foot rather than laterally on the foot. So, of course, people aren't going to get the better results with just the toe spreading exercise because you're doing very little to ensure arch continuity. Now, are you going to get an eccentric contraction of some of the other extensor musculature? Yeah. But the glute's going to have much more importance in this because of the things that I talked about. And when you're doing a glute max exercise, think about all the other things in the closed chain that you're facilitating. So it was just a really cool study.
Yeah, I mean, you know, I sat back after reading this going, well, of course that makes sense, you know. The abductor hallucis or hallucis, however you want to pronounce it, it abducts or pulls that big toe. So if you had a bunion, this would be the muscle that you would hope that you could get to help create some abduction. Yeah, there's a flexor component to it too that Ivo brought up, and if you dive deep enough in the literature, you'll understand why he's right. But I mean, it just made sense to me that, I always tell my clients, look, you got to be able to stabilize that big knuckle of the big toe. And the big toe is basically a kickstand to help you stabilize that. It's just one more little, tripod outwards that helps you stabilize that big knuckle. So it helps you stabilize the foot tripod. So if you improve the ability to stabilize that medial foot tripod, that stops the degree of pronation, maybe, especially if it's excessive, which goes back to what we talked about earlier on in this podcast was, well, if you've got a stable foot, then you're actually going to get more ankle dorsiflexion. If you get more ankle dorsiflexion, you're going to get better glute function. Oh, wait a minute. Now that glute's going to talk to that foot saying, okay, you're doing well, I'm doing well, let's do well together. But if that foot is less stable, that medial tripod tends to slide as you load it because you've got weakness of the abductor hallucis or hallucis, and the tripod is starting to slide a little bit. Now that foot starts to collapse. Now ankle dorsiflexion doesn't occur because it's falsely occurring through talar plantar flexion, or just say foot dorsiflexion, if you will, functionally. And so now the glute gets shut down. And we know this. I always do this with my clients who've got flat feet. I say, go ahead and let your foot go flat. And I kind of maybe accentuate the amount of internal tibial spin just a little bit. And I say, go ahead and squeeze your glutes. And like, oh, I can't squeeze my glutes. And then I pull them into supination and externally rotate the leg. And they go, oh, I can feel my glutes. And I said, do you see why I have to control this foot tripod better? Because it has a switch neurologically into your ability to positionally engage the glute on a neutral pelvis and a neutral hip joint. And so it only made sense to me that, this is our whole dialogue from many podcasts ago on ankle dorsiflexion and glute function. This article just took it and said, well, let's take it all the way down to the big toe. That's kind of what I got from it. So it was a good article, and it got some good attention. Hopefully people understand the broader aspect of this whole kinetic chain just from that article, but certainly from our podcast here. So
I would point out, and go to the article, okay, because it's a free full text. So you should go to the article and you should read it, okay? But if you go down through the paragraph where they're talking about, it's in the introduction paragraph, they talk about the medial lateral and longitudinal arches as well as the transverse arch. And then they talk about, in one sentence, it says, among these muscles, the abductor hallucis has been reported to control excessive foot pronation, and they have a reference there. And then they also talk about it important for stabilization of the medial longitudinal arch and used for toe off during gait. However, when you check the reference, okay, it goes to the Fielkowski article in Journal of Foot and Ankle Surgery, 2003. And in that study, what they did is they didn't really look at the abductor hallucis. They looked at all of the intrinsic musculature of the feet. And what they did is they took some volunteers, 10 of them, and they found what subtalar neutral was, controlled EMG activity from the abductor hallucis, but no other muscles in the foot during a maximal voluntary contraction while supine. So in other words, they had the person plantar flex, and they showed that it indeed would contract then. And then what they did is they infiltrated the tibial nerve with lidocaine at the ankle, and then found that, of course, EMG activity was decreased because the tibial nerve, forms the medial and lateral plantar nerves, and that's what does the intrinsic musculature in the foot. But that doesn't really prove that the abductor hallucis is important for controlling pronation, or that, it's involved that heavily with that. The intrinsic musculature as a whole, yes, but the abductor hallucis by itself,
no,
probably not. So it just goes to show you, don't believe everything you read. Check your references, when you're looking at stuff. And we only do this stuff because, we're like nerds, and this is what we do late at night and early in the morning. And when we get together with friends at cocktail parties, as we're talking about papers and weird stuff like this, or seminars that we're teaching or whatever. But it's important. And we're not saying that the exercise isn't a great exercise. We're just saying that that might not have been a fair comparison And the reason they picked this exercise is because, and they go on to say this later in the article, is that the abductor hallucis, this lift, spread, reach exercise, the toe spreading exercise, was proved in a weight-bearing posture to be more important in decreasing navicular drop than the short foot exercise, your favorite exercise. Just joking, folks. It's not Sean's favorite exercise, and it's only when in a standing or weight-bearing position. When they do it seated, they're exactly the same. It would have really been interesting to have seen people just doing the short foot as well. Although I guess they're comparing apples to apples because the people were supine and non-weight-bearing when they were doing this. But anyway, look at the references. The references are all there. All the connections to PubMed are in there. But hey, at an absolute minimum, make sure you're checking how their butt muscles are working when people are having issues, and if they're having midfoot pronation. And if you've been listening to Neuroscience any length of time, we know that the Gmax is integral. It fires at initial contact and loading response, and then again at toe off. But those are the only two times the Gmax should be firing during the gait cycle. Otherwise, it's Gmead all the way. So it's interesting.
Yep.
Sorry, got off on a secant.
Nope, that's all good. Well, why don't we finish up with this bear? Not a grizzly, not a black, but this is BEAR, Bridge Enhanced Anterior Cruciate Ligament Repair. Excuse me. I had a friend just go through this last year, so I'm very familiar with it. The first one that I have ever seen and treated myself. You probably heard me talking to this gentleman on our last podcast, 119, Carlos Lemos Jr., world-class Brazilian Jiu-Jitsu master, if you ask me. And so if it's good enough for him, it's probably good enough for just about anybody else. And he had this Bridge Enhanced Anterior Cruciate Ligament Repair where they basically take this scaffolding of... they basically take the torn ACL, they take this bridge scaffold, which is basically like a sponge, if you will, spongy-like material that they then inject with stem cells and kind of PRP-type plasma that has all these stem cell growth factors in it. And then they wrap the ACL and stitch it together around this bridging scaffold and basically allow the ACL to work its way across and heal itself, just as you would leave alone an ACL or a collateral ligament on the ankle. You just let these things vine across again, and it heals pretty well. The article here did suggest that they didn't see any infections or signs of inflammation. Carlos did have this. A mild joint infection and some inflammation, and it was strange. It was about 6-7 months post-repair, which was really bizarre. So was it related or not? I don't know. But he had to have that thing drained and all kinds of antibiotics squirted in the joint, and he's doing great now. We just, for some reason, some random infection. But as this study suggested, hamstring strength at 3 months post-operatively was significantly better in the bear group than in the hamstring autograft group. So, and I have to concur, he responded probably a third faster overall through his rehab. You have to think, you didn't have any of these terminal flexion or extension range of motions that were lost that everybody tends to have. He had full range of motion coming out of surgery. The thing we had to do was just keep him off of it and let him know that, no, it's not healed. You got to let the clock tick here. So these people do rehab faster, and this is going to be the way of the future, I think. You're going to see more and more of this. Less grafts, less patellar tendon grafts, less hamstring, less cadaver graftings and plugs and everything else. So I'd seen most of these things through a 20-year career, but this is the first time I'd seen this thing's being brand new. So I'm wondering if they're doing a lot of that out there where you are right now. Ski Central.
Not that I've heard of. They do a lot of patellar tendon allografts that they're doing for a lot of the ACL repairs that we see here. So I think that procedure is tried and true, and that's why a lot of them are using that here. I haven't looked at the studies, but I would assume you would have a little earlier return to activity with that, because basically you need to do all this rehab right up front, whereas we're waiting time for the tendon to join back together, albeit. And because we're treating a lot of ski racers and stuff like that, that maybe perhaps is the reason,
Yeah. Yeah. I know that this is a procedure that they're doing a lot overseas. A lot of the NFL and NBA guys are going over and having this done. It's certainly not new over there, but it's certainly more new here. So, but anyways, cool stuff. And you also have to think you're not having to take drilling into the either end of the femur and into the tibia to fixate the plugs on either end of that patellar tendon graft. So, and then all of a sudden, those donor sites need to be rehabbed as well. So things get, you're certainly taking a lot of things off the table here. So as they get better with this one and perfect it, and certainly with stem cells, just this stuff's just blowing up, you're going to see this kind of stuff coming along much quicker. So.
And pretty soon we'll have little nanoparticles that we can inject that will actually ferry the the clotting factors and stuff across the cleft from one to the other. It'll be sort of like, I'm trying to remember the book. It was Michael Crichton, where it was all about nanotechnology. Anyway.
Yeah, he wrote some good books.
He did. So are you going to tell people where they can order their shoe rock?
Just go out into the parking lot, guys. Well, we had some neuroscience stuff, but why don't we cut it short? I'll just mention that stuff at the beginning of the podcast, unless you really want to dive into this stuff if you had something exciting on your mind, but just new stuff out in the neuroscience world.
I think we're good. I mean, basically, one is, are we going to be replaced by machines? Are we going to be looking at the Wall-E kind of syndrome? And the other one was talking about basically brain-computer interfaces, which, is up and coming and will be a real boon for rehabilitation in particular individuals, stroke and neurological disorders, stuff like that. Yeah.
So I'll mention that stuff and we'll put it in the show notes. We're already an hour into this. We don't want to make this thing any longer for you guys. So, good podcast. I mean, if you don't have a better idea of lower extremity biomechanics from this podcast and how intricate and complicated and nuanced it is, then you maybe were drinking too many beers during the podcast or smoking some wacky weed or something like that. So go back and listen to it again, because I think this was an important podcast. We gave away some real gems here that we'd like to give away. So, all right, bud. Well, good podcast here. We wanted to thank New Balance Chicago for sponsoring the podcast. We've got them on for a few more shows here. They're doing great stuff here in Chicago. NewBalanceChicago.com, 7 stores in the Chicagoland area, and supplying a lot of our local runners here with a lot of good stuff. That doesn't mean you can't go over their website and place an order, mention the Gate guys, or get on the phone with them. I'm not sure if they're giving a discount anymore, but they certainly are providing some really good services here in the Chicagoland area. We want to thank them for sponsoring the next few podcasts. So in the meantime, or till next time, I should say, I'm Dr. Sean Allen in Chicago.
Dr. Iva Whirl up in Dillon, Colorado. We will see you in the shoe aisle.